evening.
Welcome everybody for the DGF webinar. And the first topic for today's discussion is enhancing ovarian reserve. Is it possible? And the speaker for today is Dr. Jyoti Bhaskar. Dr. Jyoti Bhaskar doesn't need any introduction. She is a principal consultant obstetrician and gynecologist for Apollo Cradle Hospital, Indrapuram. She is president DGF East. She is co-chairperson AOGT subcommittee on quality improvement. She is secretary Delhi chapter of Indian Menopausal Society. And for today's session, we have galaxy of experts, and the first of them is Dr. Anoop Gupta. Dr. Anoop Gupta is medical director and infertility specialist of Delhi IVF and Fertility Research Center. He is life member of HRA. He is member ARM and various assisted reproductive societies. Next expert we have is Dr. Archana Bajaj. Madam is director, Nurture IVF Clinic. She is senior consultant OBGYN, ART specialist, University of Nottingham, UK. She is associated with Umang, which is a non-profit organization for welfare of Kashmiri residents. And she has awards like Times Healthcare Award for Excellence in 2017. She has Rising Leadership Award by Vice President of India in 2019. She is a Global Asian of the Year 2019 award also. Next expert we have is Dr. Seema Sehgal. Dr. Seema Sehgal is expert in operative hysteroscopy and laparoscopy and infertility also. She is director and senior consultant at It's My Baby IVF Center. She is director OBGYN at CK Birla Hospital. And she has many achievements, many awards to her credit, out of which APJ Abdul Kalam Excellence Award and APJ Abdul Kalam Appreciation Awards are the ones. Next expert we have is Dr. Jyoti Bali. Dr. Jyoti Bali is director Baby Soon Fertility and IVF Center. She is Vice President DGF Central. She is founder member of DGF Central. She is recipient of many awards and she has many publications to her credit. Over to the chairpersons and experts. And I request Dr. Jyoti Bhaskar to start the session now.
So just a moment, I'll just share my screen.
Yes.
I think I've managed to do that. Is my screen visible?
Yes, ma'am, it is visible. You can just click on hide.
Yes. No, I won't. Good afternoon, everyone, and a warm welcome to each one of you for this CME today. And I've been given a topic which is of great interest to all the gynecologists. It's got, definitely for the IVF people, it is very important, but every gynecologist who's dealing with infertility. Improving ovarian reserve is something that we all really look for, and we have to do it. So first, coming on, what exactly is the definition of an ovarian reserve? This is from the ASRM, which says that ovarian reserve must be defined as a number and quality. Mind you, it's both the things, the number and the quality of the remaining follicles and oocytes in both the ovaries at a particular given age. And when we talk of DOR, that's the diminished ovarian reserve, it is a loss of the normal reproductive potential in the ovaries due to either a decrease in the quality or the count of the remaining eggs at that particular age. So if we really look at what are the possible causes of the DOR, the most important that comes to our mind is the age. The first thing that we look at when a patient walks in and asks her, what is your age? Because we know that with age, the ovarian reserve tends to fall down. The other important thing is the family history of early menopause, the conditions that cause ovarian injury, which could be any surgeries which have been done in the past, exposure to chemotherapy, radiotherapy, mumps, oophorytis, autoimmune disease, And most important is the lifestyle modifications. Now you all would all agree with me, we see much, much younger girls who are coming with a poor ovarian reserve, even at the age of 28, at the 30. So probably it is here that the lifestyle and the environmental factors and certain genetic factors do make a role in the decrease in the ovarian reserve. So coming to the most important fact that we're going to talk about, that is age, or is fertility really affected by age? We all know that the fetus is born with about 6 to 7 million oocytes. At birth, it reduces to 1 to 2 million. By the time the menarche comes down to 3 lakhs, and at menopause is just about 1,000. The loss of the oocytes is a continuous process, and the aging oocytes have been widely suggested to be a major cause of infertility. So this graph is very self-explanatory. As the age advances,
you're presenting.
So can I really know which one, where we were? Probably over here. So we were talking about the possible causes of the DOR. The most important we were saying was the advanced reproductive age, that's greater than 40 years. The family history of menopause, any condition that causes ovarian injury, which may be a surgery, chemotherapy, radiotherapy, mumps, oophorytis, autoimmune disease. Nowadays, as I said, that we do see, and you would all agree that in our practice, we are seeing younger girls, maybe at the age of 28, maybe at the age of 30, coming in with a very low AMH and a poor reserve. Probably the lifestyle and environmental factors, and even to some extent, the genetic factors may be responsible for this. The question that we all need to answer is thus, is fertility really affected by age? So if you look at the normal physiology, while a fetus is born with 6 to 7 million oocytes, at birth it is 1 to 2 million. By the time she starts at menarche, it's 3 lakhs, and at menopause it's 1,000 ovarian follicles. That means loss of oocytes is a continuous process. And aging oocytes have been mainly suggested to be the major cause of infertility. If you look at this graph, which is very, very self-explanatory, as the age advances from 20 to 50 years, the number of the follicles come down steeply, while the quantity, or I would say the proportion of the follicles which are of poor quality tends to really increase. Further, if we really look at it more deeply, with the age, there's a decline in AFC, there's a reduced inhibin B, there's a gradual decline in the AMH, while there's a steady rise in the FSH. There's a reduced cohort size, and there is a decrease in both the quality as well as the quantity of the oocytes. If you look at this particular graph, it says age of the woman and the percentage who tend to conceive in 12 months. While a young girl of 20 to 24, 86% tend to conceive by the end of 12 months. As the age goes above 35 years, only half, that's only 50% tend to conceive by the age of 12 months. If you look at the outcomes of the IVF in women who are more than 45 years, all the IVF experts would definitely agree that the cancellation rate is extremely high to 30%. Nearly 85% of them experience a pregnancy loss, and the take-home rate, that is a delivery rate, is dismal 3.1%. As the age increases, the miscarriage rate increases. And at the age of 40, we say nearly 40 to 52% of the pregnancies land up in a miscarriage. And the cause of the miscarriage is predominantly aneuploidy. Because at the age of 45, it is seen that nearly 100% of the miscarriages would be because of some chromosomal defects, that is the aneuploidy. Thus, an advancing age is actually a bane for fertility because of a decreased embryo quality, decreased spontaneous fecundity, decreased oocyte numbers, decrease in the embryo numbers, decrease in pregnancy rates with all the treatments, and an increase in the aneuploidy with advancing age. Thus, this is where comes the need for an assessment of the ovarian reserve. So if you really look at what the ACOG tends to say, why should an ovarian reserve test be performed? The main aim is to assess the quality and the quantity of the remaining oocytes to predict the reproductive potential. Who are the ones we should perform in ORT? If she's more than 35 years, she has not conceived for 6 months. If she's less than 35 years and has not conceived after 1 year of attempting pregnancy, we should do an ORT in such patients. And if the results are positive, that means if it shows that the reserve is less, what we need to tell them, that they need to counsel to be able to conceive earlier. They do not have too much time to play around. We need to give them a time scale that they need to conceive early if they really want to conceive with their own eggs. So if you really look at what are the tests that are available, clinical, the most important, as we've already discussed, is the age, the biochemical, The most important is the AMH. Ultrasonographic, it's the AFC, and dynamic, these tests are no longer used in clinical practice. So just having a look at these graphs of the FSH, if the FSH is less than 10, it's a normal FSH, we expect a good response. If it goes more than 15, it's an elevated FSH where we have a reduced ovarian reserve and we have a very poor response to our stimulation. As far as the AMH is concerned, it's a glycoprotein. It appears in the females at puberty. It's predominantly produced by the granulosa cells, and those also the preantral and the small antral cells. Important thing about AMH and the good thing is that it is not dependent on the period of the cycle. Neither is there any cycle-to-cycle variation as we see it with FSH. And even if the person has got gonadotrophin, that's an agonist, they're downregulated, AMH is not affected. So this is one particular parameter which is quite stable and can be effectively used for the management of ovarian reserve tests. So if you look at the AMH in ovarian aging, normal we would say is anything between 1 to 3 nanograms per ml. More than 3, PCOS. If it's less than 0.4, it's extremely low. The chances of their response to FSH, the chances of pregnancy rates in the IVF cycles are extremely less. The area that is 0.4 to 0.9, this is one particular area we expect a reduced response to the FSH as well as a reduced pregnancy rate. But with the new ART law, the bill that has come in, this is an area we need to try very heavily to help them conceive with their own eggs. The third, the AFC. The follicles that we are counting are only 2 to 5 millimeters, preferably on day 1 to 2. There is a lot of inter-observer as well as machine variations that tend to come up, but the gross thing that we need to understand that if the AFC is less than 5, the outcome is going to be very poor. Thus, the normal AFC is both the ovaries together is 11 to 30. More than 30, it's a PCOS. Less than 4, it is very less. And 7 to 10 is where we should not say everything is fine, but we need to just sound the patient that maybe the response to our particular drugs as well as ovulation induction will be poor in these particular patients. Thus, to end this particular aspects of the ovarian reserve test is the AMH and the AFC. AMH, the blood test, and the AFC, which is operator and us dependent, should be used together for diagnosing the poor reserve or the ovarian reserve tests. Now, this is a very important slide which I have taken from Madam, and I feel that this is where at age may be related or they are not being pregnant. But it's very important because they categorize them as DOR. If these levels are normal, will not be very aggressive in these patients and give them a strong timeline and go on move fast from IUI to an I. But still, the AMH lies near about the lower limits of the normal. We will not straight away tell them go ahead for the donor oocytes, and more women will attempt treatment with own gametes, even if the prognosis is poor. So the diagnostic criteria is poor ovarian response or poor ovarian reserve is AFC less than 5, AMH less than 1.1, and if the FSH is more than 50. Now coming to the main aspect, I know that my patient has a poor ovarian reserve. I'm not willing to send her straight away for IVF, and I want a very good response with my ART treatment. Can I improve this ovarian reserve? Is it really possible? So let us look at the various adjuvants that are available. The DHA, which is famously known as a fountain of youth. So starting with this beautiful story, actually, this was a story which is a true story. That's a 43-year-old woman who desperately searches the literature because she has been going for the IVF cycles with extremely poor response and has finally been told that you need to take a donor egg. She does her own research and she comes out across this article which was published in 2000 that DHA supplementation augments ovarian stimulation in poor responders. This was a case series, and the DHA, being a health supplement, is available in the market off the counter. She started taking this particular DHA supplements without telling her reproductive specialists, and they were really surprised to see that as her cycles kept on going, the number of oocytes and the number of embryos tend to increase. And that is when they asked her, what are you on? And they found out it was the DHA, and that's when all the studies started after that. So if you really look at the DHA, it has peaked between 20 to 30 years in men and women, and after that it tends to come down, and this is actually called the fountain of youth. The androgens, that's what the DHA is extremely important because it affects all the stages of the follicle maturation. If you look at this particular graph, you would see whether it's a primary, it's a preantral, or it's an early antral follicle. All of them have got receptors for the androgen. And the androgen, along with the FSH, together in synergism, tends to act to bring about a good follicle maturation. Thus, DHA increases the AMH levels, increases the FSH receptors on the granulosa cells. It causes an increase in the ovarian steroidogenesis. It prevents the granular cell apoptosis. As a result, it tends to increase the ovarian reserve. It increases the recruitable oocyte pool, and hence it increases the pregnancy rates. If we look at the miscarriages, the DHA, when had been supplemented, there was a reduction in the miscarriage to the tune of 40 to 80%, even in those women who were more than 35 years of age. Thus, if you look at the beneficial effects of DHA, it increases the cell and the embryo counted quality. It increases the chromosomally normal embryos. It gives us much greater number of embryos for transfer and IVF treatments. It accelerates the time from pregnancy in the fertility treatments, and it increases even the spontaneously conceived pregnancy. This is the term I really liked about this, is that it tends to regenerate the ovarian environment. He says it's the ovarian environment which actually gets old as a woman gets older. It is not the resting oocytes. Thus, DHA and all the other adjuvants that we tend to do in normally fertile older women, they tend to bring about regeneration of the ovarian environment. And it was this paper where they said that like supplementation with folic acids tends to prevent the neural tube defects, DHA may achieve favorable public health consequences by potentially reducing aneuploidy and spontaneous pregnancy losses in the general population. So if you really look, when we are giving DHA, it can be given both, and it improves the spontaneous natural conception. It improves the results of our IUI, IVF outcome, and pregnancies in women who have had confirmed DOR. The dose is 75 milligrams, given for at least 4 months. The effect comes out quite quickly. Within 2 months, we will be able to see the effect. But yes, at least 4 to 6 months is the time duration when DHA should be given. As soon as the pregnancy test is positive, it needs to be stopped. If you look at the safety of this drug, it is extremely well tolerated. It is much safer than the other androgens. It has a few side effects like breast tenderness, reversible hirsutism, and mild to moderate acne due to sebaceous secretion. We talk about the side effects, but this drug has got side benefits. And that is that improved overall feeling of being physically stronger, improved sex drive, feeling of being mentally more sharper, and feeling of better memory. So these side benefits with the actual benefit of improving the pregnancy rate, that is what DHA is about. The other drug, that's melatonin, it's known the super antioxidant. It was first isolated in 1958, synthesized by the pineal gland, and then it is pushed into the blood, and from the blood, it enters into the ovarian follicle. It's known as a broad-spectrum antioxidant or societal antioxidant. The dose of melatonin is 3 milligrams, and it has to be given at night. It tends to improve the sleep pattern, and that is one of the extra benefits that one gets with this drug. As already said, it is the most important antioxidant. It does not promote oxidation under any circumstances. And even its metabolites, they too tend to act as antioxidants. Further, it tends to enhance the activity of endogenous antioxidants like glutathione peroxidase or superoxide dismutase. With other oral antioxidants like vitamin C, vitamin E, it tends to further enhance their antioxidative property. The primary and the primitive function of melatonin may be its actions as a receptor-independent free radical scavenger or a broad-spectrum antioxidant, and this forms the basis of its health. If you look at this particular diagram, it's very complex, but all I would like to say is that the level of the melatonin within the follicular fluid is much higher than that it is in the blood. If it's transferred into the follicle through the basement membrane, it attaches to the granulosa cells, to the theca cells. It tends to prevent the ROS. As a result of it, dominant follicle tends to further grow. There's an ovarian maturation. It prevents apoptosis. It improves the receptors, both FSH and LH. That is, it has got a multifold action, but the predominant is because of its antioxidant effect. So this tends to define its effect on the ovum as well as its effect on the follicular fluid. As far as the ovum is concerned, it improves the oocyte quality, the maturation, protects ovum during ovulation, and improves the fertilization rate. Because of its presence in the follicular fluid, it tends to improve the progesterone levels and reduces the follicular atresia. In short, it affects all stages of follicular development, oocyte maturation, as well as the luteal phase. Vitamin D3 is yet another one which we all know. It's a one drug which affects every aspect of our body, and now we are looking at its role in reproductive physiology. It plays an important role in the follicular development, differentiation, and oocyte development, illustrated at the fermentation. So if you really look at it at every aspect of reproduction, it has an important role to play, yet there's an inconsistency as far as the various reports or the evidence has been there, whether it has the capacity to influence the ovarian reserve. The studies are still going on, when we need much greater studies to really find out its effect on the ovarian reserve. But it's still understood that vitamin D supplementation may be considered in the fertility management of patients with DOR, as it increases the AFC, it increases the AMH, and it causes a decrease in the FSH levels. And this is yet another mitochondrial nutrient which has also got a role to play in the DOR patients. That's the coenzyme Q10. It's all oil soluble, it's vitamin-like substance, it's mainly present within the mitochondria, and it is used as a dietary supplement. The effect of CoQ10, if you look at it, is mainly tends to improve the ATP production in the mitochondria, and it also is an antioxidant. As a result, it restores the normal energy production in the ovary and protects it from the oxidative stress. Thus, coming to the end, the key understanding is that DOR is a reality, and it is a major challenge for the reproductive physicians. Age alone is a major determinant of DOR, POR, as well as the miscarriages. ORT test should be done when we have a specific aim for doing it, and we should not do it indiscriminately in all the patients. The two ORT tests which have stood the time is the AMH and the AFC. Adjuvants definitely have a very important role in improving the ovarian reserve. DHA and androgen has been shown to improve pregnancy rates and reduce miscarriages. Melatonin is super antioxidant, and it acts by reducing ROS. Vitamin D3 has a role to play in every aspect of the reproductive physiology, but we need more reports to be able to actually identify its main role. CoQ10 is a mitochondrial nutrient which also acts as an antioxidant and a source of ATP. So let us all put forth or put behind the biases and say that forget all the reasons that it won't work and believe the one reason that it will. And here, the one reason that we can together give all of them is through this particular drug, the AMH fix, which has got DHA 75 milligrams, melatonin 3 milligrams, vitamin D3 3000 international units, and they have added also the folic acid. That's 4.5 milligrams. And this has to be given at night because it contains melatonin, single dose, for a minimum period of 4 months before we are able to see an extremely good result, or we take the patient over by any of the ART methods. Thank you so much.
Thank you, Dr. Jyoti, for such an elaborate explanation of everything for the subject. Now I request the experts to give their opinions. First, Dr. Anoop Gupta, please.
Sir, we cannot hear you, sir. Sir, you're muted.
Sir, you muted.
I think he's unable to unmute himself. So that time, Dr. Archana can.
I request Dr. Archana to give her expert comments.
Thank you so much, ma'am, for an excellent presentation. I think you've comprehensively, included all the possible perils of having a low AMH and how to go about it in trying to improve. Of course, I do understand that we were trying to be specific to the medical management. But of course, as you said, lifestyle modification, things like dietary improvement, adding stuff like berries, nuts, seeds, especially flax seeds, all this also seems to have a role. How important or how scientifically relevant, we don't know. Apart from that, modifying the ART protocols, adding testosterone a pre-cycle before are all things which can be evaluated. So overall, I think, almost everything that could be discussed upon. The only thing I'd like to add here, and which you have also specified, that sometimes, patients and some of us tend to push the business of retrieving follicles to get, to a good number, and sort of this pooled pooling of oocytes in people with low AMH. So I think we should have a clarity on where to draw a line in using oocytes of the patient with a poor AMH, and where to, move forward or guide the patient forward towards a donor cycle. So this fine line needs perhaps to be defined better, and also, the perils of having a repetitive egg stimulation and this business about just getting, as many oocytes as we can. So as clinicians or as healthcare providers, sometimes, we tend to get pushed by the patient to keep stimulating and retrieving to be able to get a good egg pool so that their own oocytes can be used. So somewhere, I think along the line, we have to be very clear in our minds how far to push a low AMH and where to draw the line for using the donor. Other than that, I think Sam's already done a very comprehensive.
I really appreciate what you have spoken very well. You have covered every point. But let me tell you, you cannot really reverse your AMH. This is proven, in all the knowledge what we have gained so far. So ultimately is how to deplete the variable, how to stop the depletion. So best part is, I feel, earlier you start the right treatment for the patient. Like when the patient walks into a general physician, we start with clomiphene and all. And number of cycles of clomiphene are given. And then you keep on losing your quality eggs. So instead of conserving our egg, we are really losing and make them lose more and more eggs, which are future babies basically. So we should try to have controlled depletion of the eggs. We should limit our use of clomiphene. And if a patient is coming into an higher age with low AMH, with low AFC and poor ovarian response, initial cycles, then I feel we should offer them the treatment of choice. We know that this person is wrong, so give them the best. And what I have seen in my practice, you have to decide how to go about it. Double stimulation, maybe cooling, or maybe long-term use of permanent citrate along with HNG. This is what I have been doing. No doubt, supplements have their own role, but I think we should not wait for the supplements to act, because that time also you lose. In those 4 months time, instead of patient gains, the loser. So there is not that much of time with the patient, so that we wait and give DHEA for 4 months and then wait for the result. So idea behind is morally lift them up, elevate their mental status, let them have proper sleep, check their prolactin levels, check their stress level, make them more to consume it, and give other supplements that make the environment very friendly to them. Try to counsel with the husband so that they have more frequent interviews. So look at the other parameters also. It is always, most of the time, missing. So this is what I try to do with the patient. But I know Ovarian Reserve, you have to take a keyword. Otherwise, nothing. So we are very, very clear. With DHEA, we have seen the role of DHEA is not to do anything other than this. So we are dependent on this.
Sir very rightly said, that you cannot reverse the age. But however, all ART clinicians, all gynecologists use DHEA with melatonin, with folic acid. तो उसके में rational बंद तो कोई भी नहीं कर रहा.
See, but I feel there should be more stress on, don't waste patients' time. You start DHEAS and all supplements, CoQ, vitamin E, folic acid, melatonin, whatever you can. And prolactin is one thing which most of the time is ignored. And these patients, no doubt, they are under stress. So if you are able to cultivate them into positivity, put them to more regular intercourse, make them more friendly environment for them. So then they become more positive. And instead, what I do is I put them straight to IVF. I talk to them about double stimulation. I give them clomiphene citrate for 10 days along with it. The idea behind is to get more eggs. If there are patients who are very, very adamant, I give ovarian rejuvenation to them. And I have seen that works. Not that much as you expect, but yes, it is working. It will double the AFC count. It increases the ovarian response. So those kind of things can work, but only to a limited extent.
Dr. Jyoti Bali, what is your comments about, marginal decrease ovarian reserve?
I think Sir and Dr. Archana have covered quite a bit. To Dr. Archana's comment, I would just add that she was very right in saying that a clear definition should be, a plan should be made. The roadmap should be clear as to how far you will go before embarking on donor egg cycles. So look, I think the plan should be very, very clear right in the counseling that look, we will look at the numbers, quality, finally the embryos that we make out of the first cycle. Depending upon that, how much would you take the patient that far? Maybe if they are very good 2 embryos, do they want to do embryo pooling or not? Maximum 3 cycles if the embryos are very good in the very first setting. Otherwise, the patient should be primed that yes, this will be the full stop here after 3rd cycle. And this result, otherwise we move on to the next step, that is donor egg cycle. If the roadmap is given right in the beginning and repeated in every counseling session, they are primed as to the results. Cannot be a magic to any therapy that we are giving them, be it DHEAS, melatonin and flax seeds and whatever diet, sleep 8 hours, stress-free environment, what advice we may give them. But I think this roadmap needs to be documented, repeated in every counseling session, and a plan clear as to where will be the end. The end is having a baby soon and having in hand. So how far would we go with that patient? How much timeline it will take? So once this counseling is clear, I think these patients can be handled well. And I agree with Sir having said that it cannot be reversed. Dr. Sharda Jain, Madam, also said. We know that we are in a situation, but time needs to be utilized. We cannot be wasting time and sitting over it. Action needs to be clear, taken quickly, and then plan to be quickly. First cycle, second cycle, 3rd cycle, full stop, move to the donor egg. If they are good embryos, pull them and do a FEP cycle.
Now,
this is all about the IVF specialist speaking, but since we have so many gynecologists present over here, so what do we do if I get an AMH of 1? I get an AMH of 1, I get an AFC count which is 7 to 10. I'm not going to send her straight away to an IVF specialist.
No.
This is where the role lies of giving all these particular adjuvants.
7 to 10 at what age? Age is also an important criteria with 7 to 10. If 7 to 10 AMH of 1, and what is the age? If she's a younger woman, please take her up and decide what you want to do.
Yeah. So
but again, they also need to define after 6 months what comes down.
Yeah, the road plan has to be made, but not every person is going to be landing up there.
Very
Dr. Seema Sehgal's opinion is also required.
I invite comments from Dr. Seema Sehgal. Are you there? Dr. Seema Sehgal, ask her to make a comment. From the point of view for gynecology, what will be your comment about, if the image is just borderline 1.7, 1.6, 1.5, what will be your advice?
If I get a lady who's about 30 years of age, she's been trying for the last 2 years. I do an AMH which comes out to be about 1.3, 1.4. AFC count is somewhere about 7 to 8 at that one. I'll definitely start her on all these supplementations while investigating of infertility. So I get a time of about 2-3 years where I do. I make with her a roadmap that how many ovulation inductions I give her. I'm not going to go unnecessarily with them. Maximum 2 cycles with, and if required, move on to an IUI movement. So I have a plan that in the next 6 to 7 months, I would have done something more. She has been pregnant, shift over to an IVF consultant. But yes, there is a role of giving all these adjuvants while you're preparing, while you're investigating, and while you're moving ahead from one end to the other. Even for many times, many people have written the comment that they were on DHA and the patients became pregnant while they were being investigated. So yes, it's not very well. Yes, ma'am.
I think what I will suggest to you, I will speak from the point of view that I am not an IVF specialist. See, the question is, the people who are not an IVF specialist, they sit over patients for a very long time. It goes without saying whether you go to start all these patients where there's a borderline AMH or borderline IFC count, you would definitely start them with the DHA, mother-to-baby, and things like that. I find, it works in patients who have married very late and who have never had an exposure before. It really works very well in those patients. But if it has to give a response, it will give a response in 6 months' time. It will not give a response. My only request to all people that if the AMH is low and if the AFC count is low, please send them to the ART people. Don't keep on trying on those people. So I will like on this to make Dr. Bajaj to make a comment on this. When a gynecologist should refer them to a specialist. A small comment by you, by Dr. Anoop and Dr. Bali.
Yeah, ma'am. So as you said very effectively, it's a bad practice to keep sitting over somebody with a low AMH. From what I would expect of a person, if you have an AMH below 0.5, I think straight away the thing should be to put them on whatever adjuvants you have and straight away send the patient to a person who has more expertise or more experience, I would say, in dealing with a person like this. If an AMH between, say, 0.5 to 1, start the medication, do 1 or 2 cycles of ovulation induction, no outcome, move forward. On an AMH between 1 and 1.5, I think that should be a person you should be giving more time as a gynecologist. So all the adjuvants, all kind of lifestyle modification, good ovulation induction over 3 cycles, coupled with or without an IUI. If you still don't get an outcome, I think time to move ahead. For AMH over 2, I think it's anybody's call, an individual patient-to-patient assessment. But by and large, I would really, categorize it in these 3 blocks.
Yes, very well done. Yes.
Thank you very much, ma'am.
Madam, you're going to.
Dr. Bali, what is your opinion about this?
Ma'am,
how are you going to categorize when they should refer it to the
less than 1, yes, immediately. And I would say less than 1, don't sit over it. And age is an important criteria. Younger patient, less than 1, immediately reference.
Coming to the senior most ART expert in the city, I will ask Dr. Anoop Gupta, when will you like the gynecologist should refer to the ART expert, depending upon AFC and AMH and age? Sir, over to you.
What I feel is we should really look for the other reason other than the AMH, because that can be easily treated. And if you find the AMH is the only culprit, then I feel we are wasting patients' time. So immediately, whatever the AMH is, everybody has a desire to have their own baby. They want to see their own image in the baby. And they have every right to have it. So don't delay. And if you feel like AMH is the factor, rest is fine, then I feel IVF should be the first choice. Because this patient has very, very limited time and limited chances to have a baby. Don't delay at all.
I'm the youngest person to become an ART specialist when I compare to these people. Now, what is my opinion on this? I think, Indian women, you should not forget their ovarian aging is 5 years earlier. Yes. So it is for the other people, if it is 35, 36, 37 years, for us it is 30 years. One thing. Secondly is, any time the AMH is less than 1.5, this is not your area. Exactly. Please send them away to the ART expert. Dr. Bajaj has been very conservative, 0.5. No, madam, less than 1.5, they should go to the ART specialist. Tell them that they should go. You can definitely play, if she is less than 30 years, you can play between 1.5 to 2 years. And I think, with that particular remark, there is some homework for you to do it. I think we must move on to the second presentation.
And one more thing I would like
Yes,
to
sir.
here is when you're talking of AMH less than 0.5 and age more than 37, I feel that should be the cutoff to advise for an egg donation. Because those sort of patients, they keep on believing their doctors who are saying that I have very good success rate in AMH of 0.1 and all that thing. So that is very detrimental. It's very bad for the patient. And they keep on trying and they can, unluckily or luckily, they don't get pregnant because they will land into missed abortions or any all sort of things. I feel so if it is less than 0.5, 37, 5 years of marriage, advise them straight away so that they get a healthy baby.
मैं तो कहूँगी डॉक्टर मेरी प्रैक्टिस में लेस देन 1 AMH होगा तो सेल्फ साइकिल में कुछ नहीं होता unless you are trying to
even I see cutoff should be less than 0.5. Perfect
for a donor cycle less than 0.5, but all the people who are not ART specialists goes without saying, whenever your AFC is less and the AMH is also less, we definitely start them on a DHEA plus.
And I feel we should start counseling the patient, parents, to marry their daughters early, giving them, instead of giving them house and all,
So that's a very controversial area, sir.
Yeah, they should encourage them for egg freezing, which is